This is the activity video for Chapter 27, Fluid, Electrolyte, and Acid-Base Balance. So Part 1, Acid-Base and Balance. Number 1, before we look at some clinical cases, review the normal levels for pH, carbon dioxide partial pressure, oxygen partial pressure, and bicarbonate ion concentration in arterial blood. So the normal pH should be between 7.35 and 7.45. The normal bicarbonate ion concentration should be between 21 and 28 milliequivalents per liter. And then for the gases, note that the question is asking for the normal levels in systemic arteries. So you may want to go back to Chapter 23 to review how oxygen and carbon dioxide levels change in the arteries versus the veins, so whether the blood is deoxygenated or oxygenated. So if we're looking at carbon dioxide levels in systemic arteries, this would be in oxygenated blood, and the normal carbon dioxide level should be around 40 millimeters mercury. So as we covered in Chapter 27, carbon dioxide levels can range between 35 millimeters mercury and 45 millimeters mercury, but this is what we would expect to see in systemic arteries. The normal oxygen partial pressures should be between 95 and 100 millimeters mercury. So Part 1, case number 1. A 14-year-old girl with cystic fibrosis has complained of an increased cough productive of green sputum over the last week. She also complained of being increasingly short of breath, and she is noticeably wheezing on physical examination. Arterial blood was drawn and sampled, revealing the following values: pH of 7.3, carbon dioxide pressure of 50 millimeters mercury, oxygen pressure of 55 millimeters mercury, bicarbonate ion concentration of 24 milliequivalents per liter. So now we'll look at the Case 1 questions. Number 2, review from Chapter 23. What is cystic fibrosis? Would this be a restrictive lung disease or an obstructive lung disease? So cystic fibrosis is an inherited disease that results in the respiratory mucosa producing a thick, dense, viscous mucus. So the thick mucus means that the mucociliary elevator doesn't function as it should, which can result in frequent respiratory infections. And the thick mucus also makes breathing difficult. So here's a picture to show a respiratory passageway. You get this very thick mucus buildup, which both blocks the airway and results in frequent bacterial infection. So this would be an example of an obstructive lung disease because there is an increased resistance to airflow because of the thick mucus. Number 3, how would you classify this girl's acid-base status? So remember, there are a series of questions to ask when you're classifying a patient's acid-base status. So let's review these steps. First, you should check the pH. Then you should check the carbon dioxide levels. Then you should check the bicarbonate levels. So first, if we look at the pH, this girl's pH is lower than normal. So she has a pH of 7.3, and normal should be between 7.35 and 7.45. So she is in a state of acidosis. Second, her carbon dioxide levels are higher than normal. Normal should be 40 millimeters mercury for arterial blood, and hers are 50 millimeters mercury. And then third, her bicarbonate levels are actually within the normal range. Bicarbonate levels should be between 21 and 28 milliequivalents per liter, and hers is 24 milliequivalents per liter. So given these values, especially the low pH with the high carbon dioxide, this girl has respiratory acidosis. Note that she also has a much lower than normal oxygen level, so it should be 95 to 100 and it's only 55. That indicates that she's having difficulty breathing, which is called hypoventilation. Also note that the normal bicarbonate ion levels actually is telling us that this is an acute attack of respiratory acidosis and compensation has not yet kicked in. So number 4, how does cystic fibrosis cause this acid-base balance, and show the equation. So due to the thick mucus in the airways, this patient is unable to breathe effectively, which is resulting in hypoventilation. And as mentioned earlier, this is also showing up in her reduced oxygen levels. Because of the decreased breathing ability, her carbon dioxide levels have risen. And remember that almost all of the cells of the body are constantly producing carbon dioxide every second of every minute of every hour of every day of every year. So if you can't breathe the carbon dioxide out, the levels can quickly build up in the blood. So the elevated carbon dioxide levels will result in the formation of additional carbonic acid. So if you remember, carbon dioxide combines with water, and the enzyme called carbonic anhydrase will convert those two molecules into carbonic acid. The carbonic acid then dissociates into hydrogen ions and bicarbonate ions. So immediately the carbonic acid will release hydrogen ions and bicarbonate ions. And the increase in the hydrogen ions will lower the blood pH, resulting in acidosis. Remember, pH is a direct measurement of hydrogen ion concentration. So when we increase the number of hydrogen ions, we decrease the pH or make it more acidic. So this equation then is doing what we say shifting to the right. So we are making more carbon dioxide because we're not breathing enough of it out. And so as a result, we are making more acid in the form of hydrogen ions. Number 5, how would the kidneys try to compensate for the girl's acid-base balance? So the kidneys would compensate by increasing the rate of tubular secretion of hydrogen ions, so more hydrogen ions in the urine, and increasing the rate of tubular reabsorption of bicarbonate ions, so keeping the bicarbonate ions in the blood. So here's a picture. So if you have hypoventilation that causes an increase in carbon dioxide pressures, that's going to cause the pH of the blood to fall, which is called respiratory acidosis. So the kidneys can compensate by secreting hydrogen ions and reabsorbing bicarbonate ions. So once the kidneys do start the compensation, she should have more hydrogen ions in her urine. And you would also expect to see an elevation in the blood bicarbonate levels. So elevated blood bicarbonate levels can be a sign of compensation for chronic respiratory acidosis. And like I mentioned earlier, because her bicarbonate levels are still normal, she has not yet had this compensation kick in. Number 6, describe some other causes of the same type of acid-base disturbance. So anything that would result in hypoventilation, which is reduced breathing ability, would result in respiratory acidosis. So here's a picture from a nursing website to show you some of the signs and symptoms of respiratory acidosis. They also have a little section on some of the causes over here. We're going to list a few more. But the key with respiratory acidosis is that the pH and the CO2 levels are opposite. So pH drops, CO2 levels rise. So some of the things that can cause hypoventilation include asthma attack, chronic bronchitis, emphysema or other chronic obstructive pulmonary disorder, muscular dystrophy. So if you have a weakness in your muscles, then that's going to include your diaphragm and external intercostal muscles, so you won't be able to breathe as efficiently. choking or drowning, both of which will stop your breathing completely. Opioid overdose, so taking too much morphine or heroin or any type of opioid will slow your breathing to dangerous levels. Amyotrophic lateral sclerosis, or ALS, is when you have damage to the motor neurons. So again, you can't get signals to your diaphragm and your external intercostal muscles, so you have difficulty breathing. And a pulmonary embolism. So part number 1, case number 2, a man with a myocardial infarction. So a 76-year-old man complained to his wife of severe substernal chest pains that radiated down the inside of his left arm. Shortly afterward, he collapsed on the living room floor. Paramedics arriving at his house just minutes later found him unresponsive, not breathing, and without a pulse. CPR and electroconvulsive shock were required to start his heart beating again. Upon arrival at the emergency room, the man started to regain consciousness, complaining of severe shortness of breath and continued chest pain. On physical examination, his vital signs were as follows. His systemic blood pressure was 85/50, his heart rate was 175 beats per minute, and his respiratory rate was 32 breaths per minute. His breathing was labored, his pulse was rapid and weak everywhere, and his skin was cold and clammy. An ECG was done, revealing abnormalities. Blood testing revealed markedly elevated creatine phosphokinase, or CPK, levels of cardiac muscle origin. Arterial blood was drawn and sampled, revealing the following values. His pH was 7.22, carbon dioxide was 30 millimeters mercury, oxygen was 70 millimeters mercury, and bicarbonate levels were 2 milliequivalents per liter. So number 7, what do you think happened to this patient, and what evidence supports your diagnosis? So this man suffered a myocardial infarction, also commonly known as a heart attack. And just to refresh your memory, this occurs when you have a clot in one of the coronary arteries, which cuts off blood supply to the heart muscle itself. And then without that blood supply, the muscle actually starts to die. And once cardiac muscle cells are dead, they're dead forever. So the evidence in favor of this diagnosis includes his severe chest pain that was radiating down his left arm and his subsequent collapse. The fact that he had no pulse when the paramedics arrived shows that his heart stopped beating. An abnormal ECG indicates damage to the heart's conduction pathway, as we covered in Chapter 20 earlier this semester. And elevated cardiac CPK levels indicate cardiac cell death from a lack of blood flow, which is called cardiac ischemia. And we also talked about this earlier in the semester. CPK is a enzyme that should normally only be found inside of cells, so both cardiac muscle cells and skeletal muscle cells. And once you see CPK in the blood, that is a symptom that one of these cell types has died. And since in this case it was cardiac CPK, that tells you that you actually have cardiac cell death. So number 8, how would you classify the patient's acid-base status? So before we get started, I know that a lot of people want to jump immediately to respiratory acidosis because it was mentioned that the man stopped breathing. And so while he may have had acute respiratory acidosis when he did stop breathing while he was at home, the paramedics have since restarted his heart. And note that these blood values we're looking at are his values after arriving at the hospital. However, his period of not breathing from earlier has contributed to his lower than normal oxygen levels. So remember that when we're evaluating an acid-base condition, we need to first look at the pH. So his pH is lower than normal. Normal is between 7.35 and 7.45. His is 7.22. So this is definitely a case of acidosis. Second, we look at carbon dioxide. So his carbon dioxide is lower than normal. Remember, normal is 40 millimeters mercury. His is 30. That right there tells you that this is no longer respiratory acidosis, because with respiratory acidosis, you would have a low pH and a high carbon dioxide. So with respiratory acidosis, the pH and the carbon dioxide levels are opposite. We don't see that here. Here we see a low pH and we see a low carbon dioxide level. Furthermore, if we look at his bicarbonate levels, they are lower than normal. Normal should be between 21 and 28 milliequivalents per liter. His is only 2 milliequivalents per liter. So when you see a low pH and a low bicarbonate level, so when the pH level is the same as the bicarbonate level, that is an indication that you are looking at metabolic acidosis. So the low carbon dioxide level that he has actually suggests that his respiratory system has already started compensating for the metabolic acidosis by increasing his breathing rate. And this is confirmed by the observation that his respiratory rate is higher than normal, so he's currently breathing at 32 breaths per minute instead of the normal 12 to 16 breaths per minute. So number 9, what specifically caused this man's acid-base disturbance? So when his heart stopped beating, no oxygen was being delivered to the body's tissues, causing a state of hypoxia. The tissues that have the capability to perform anaerobic respiration, like skeletal muscle, would have then started using that method to generate ATP. A byproduct of anaerobic respiration is the production of lactic acid. So this man essentially had lactic acidosis. And as lactic acid builds up in the bloodstream, it lowers the pH of the blood because we're actually adding an acid, we're adding hydrogen ions, so it lowers the pH, causing acidosis. Even after the heart starts beating again, it can take hours for the body to recycle the lactic acid back into a less dangerous form. So also note, the body is adding more and more hydrogen ions during lactic acidosis. And as the hydrogen ions are being produced, they are being combined with bicarbonate ions to produce carbonic acid. The carbonic acid is then being converted to carbon dioxide, and it is then being exhaled. That's why he has a higher than normal breathing rate. But that also means that you're using up all of your available bicarbonate ions in an attempt to counteract those extra hydrogen ions that are being produced. And this is why you end up with a lower than normal bicarbonate level in the blood. So number 10, how has his body started to compensate for this acid-base disturbance? So the man has already started hyperventilating, which is a faster than normal breathing rate, to compensate for the metabolic acidosis. We can see that this compensation has kicked in because of his lower than normal carbon dioxide levels. In time, the kidneys can also respond by increasing the rate of tubular secretion of hydrogen ions, so putting more hydrogen ions into the urine, and increasing the rate of tubular reabsorption of bicarbonate ions, meaning keeping bicarbonate ions in the blood. So this is the same kidney response as we saw for respiratory acidosis. So here's a picture. So if you have metabolic acidosis, you are adding hydrogen ions. So to compensate, you will increase your respiratory rate to breathe some of those out in the form of carbon dioxide, and the kidneys will also secrete hydrogen ions while generating bicarbonate ions to stay in the bloodstream. So keep in mind, though, that when you do have a condition of metabolic acidosis, the lungs are able to respond more quickly than the kidneys because it's easier to change the breathing rate than to wait on the kidneys to filter all of these extra ions out of the blood. Number 11, describe some other causes of the same type of acid-base disturbance. So anything that would result in an increase in hydrogen ion production or an increase in hydrogen ion retention, or a loss in bicarbonate ions would result in metabolic acidosis. Again, here's a little picture to help you see some of the signs and symptoms of metabolic acidosis. And when you are looking at metabolic acidosis, notice that the pH and the bicarbonate levels should both equally be low. So low pH, low bicarbonate. So some of these conditions could include diabetic ketoacidosis, severe diarrhea, which is actually a loss of bicarbonate ions, renal failure, so if the kidney has difficulty getting rid of hydrogen ions, methanol or ethanol toxicity, because both of these forms of alcohol are actually converted to acetic acid when they're being broken down, which raises the acid content of the blood. And then I didn't list lactic acidosis because that was the focus of this particular case. So part 1, case number 3, man on mechanical ventilation. So an elderly gentleman is in a coma after suffering a severe stroke. He is in the intensive care unit and has been placed on a ventilator. Arterial blood was drawn and sampled, revealing the following values: pH of 7.5, carbon dioxide of 30 millimeters mercury, oxygen 100 millimeters mercury, and bicarbonate levels at 24 milliequivalents per liter. So number 12, how would you classify this patient's acid-base status? So remember, let's look at the pH first. So his pH is higher than normal. Normal is between 7.35 and 7.45, and his is 7.5. Next, we look at carbon dioxide. His carbon dioxide is lower than normal. Normal would be 40. His is 30. So right away, I see that pH and carbon dioxide are opposite to each other. One's high, one's low. That's going to clue me in that I'm looking at a respiratory issue. And then I'm also going to look at his bicarbonate levels, and in this case, his bicarbonate levels are normal. So normal is between 21 and 28. His is 24. So given these values, this man has respiratory alkalosis. And it's alkalosis because the pH is higher than normal. So number 13, what could be this man's problem and how would it raise the pH of the blood? Show the equation. So since this man is on a ventilator, the most likely cause is that his ventilator is set to a breathing rate that is too high, causing him to be passively hyperventilated. Hyperventilation will increase the rate at which carbon dioxide is eliminated, which is why his carbon dioxide levels are lower than normal. As carbon dioxide levels decrease, the equation gets shifted to the left. Let's look at the equation. So the equation gets shifted to the left this time. So this is causing hydrogen ions to join up with bicarbonate ions to make carbonic acid, which carbonic anhydrase then breaks down into carbon dioxide and water. So this is causing the hydrogen ions to be used up in order to create more carbon dioxide to continue with the hyperventilation exhaling. So the equation this time is moving to the left. So as the hydrogen ions are used to make more carbon dioxide, the pH increases, which causes alkalosis. Number 14, how might the kidneys respond to this acid-base disturbance? So the kidneys could compensate by increasing the rate of tubular secretion of bicarbonate ions, so this time we're putting bicarbonate into the urine, and increasing the rate of tubular absorption or reabsorption of hydrogen ions, so we're keeping hydrogen ions in the blood. So in response to respiratory alkalosis, the kidney is going to end up excreting in the urine more levels of bicarbonate. So in an acute phase of respiratory alkalosis, the bicarbonate levels are normal, like we see in this patient, because the renal compensation has not yet kicked in and gotten rid of enough bicarbonate to change the bicarbonate concentration. However, once renal compensation kicks in and the bicarbonate ions are lost in the urine, you could see a decrease in bicarbonate levels. So since this patient still has normal bicarbonate levels, he has not been in respiratory alkalosis for too long. Number 15, describe some other causes of the same type of acid-base disturbance. Anything that would result in hyperventilation or an increased breathing rate would result in respiratory alkalosis. So again, here's a little picture for you. So with respiratory alkalosis, you're going to have high pH and low carbon dioxide. So pH and carbon dioxide will be opposite to each other. So things that can cause this are extreme anxiety, like having a panic attack, high altitudes where oxygen levels are really low, which forces you to breathe faster, and brainstem injuries. Also, mechanical ventilators that aren't set correctly, but that was the focus of this particular case study. Case number 4, woman with severe vomiting. A 28-year-old woman has been sick with the flu for the past week, vomiting several times every day. She is having a difficult time keeping solids and liquids down and has become severely dehydrated. After fainting at work, she was taken to a walk-in clinic where an IV was placed to help rehydrate her. Arterial blood was drawn and sampled, revealing the following values: pH 7.5, carbon dioxide 40 millimeters mercury, oxygen 95 millimeters mercury, bicarbonate levels 32 milliequivalents per liter. So number 16, how would you classify this patient's acid-base status? Again, we're going to start with the pH. Her pH is higher than normal. Normal is between 7.35 and 7.45. Her pH is 7.5, so she is in a state of alkalosis. Her carbon dioxide level is normal, so normal is 40 millimeters mercury for arterial blood. Hers is 40 millimeters mercury. So right away I can see that there is no association between pH and carbon dioxide levels, so that is a big clue that I am looking at metabolic acid alkalosis. But let me go ahead and check her bicarbonate levels. Her bicarbonate levels are higher than normal. They should be between 21 and 28, and hers are 32. So when the pH and the bicarbonate levels have the same sort of distortion in the same direction, so if the pH is high and bicarbonate is high, that is an indication that you are looking at metabolic alkalosis. So number 17, why would excessive vomiting cause her particular acid-base disturbance? Vomiting results in a loss of hydrogen ions from the elimination of the stomach acid through the vomitus. In the process of making stomach acid, the parietal cells of the stomach also secrete bicarbonate ions into the blood plasma. So this is a review from chapter 24. You have the parietal cells that are in the glands within your stomach, and the parietal cells take carbon dioxide and they use it to make bicarbonate ions and hydrogen ions. The hydrogen ions get pumped out into the lumen of the stomach. The bicarbonate ions get moved into the blood and they are swapped for a chloride ion, which is also pumped into the lumen of the stomach to create hydrochloric acid. So when you are vomiting, you are losing these hydrogen ions, and then again notice you are secreting bicarbonate ions into the blood as you are making more acid to replace the hydrogen ions that you just vomited up. So therefore, excessive vomiting will result in a loss of hydrogen ions and a corresponding increase in bicarbonate ions, causing alkalosis. This is why we saw an elevation of bicarbonate levels. So number 18, how would the kidneys compensate for this acid-base disturbance? So whenever you have a case of alkalosis, whether it's respiratory or metabolic, the kidneys will compensate by secreting bicarbonate ions into the urine and increasing the reabsorption of hydrogen ions or keeping hydrogen ions in the blood. Now note the lungs can also compensate for metabolic alkalosis by decreasing the breathing rate, which would allow more carbon dioxide to build up in the blood, which could also help to raise the hydrogen ion content. So compensation for metabolic alkalosis includes decreasing the respiratory rate to elevate carbon dioxide and to have the kidney secrete bicarbonate and keep behind the hydrogen ions, because the root cause of metabolic alkalosis is the removal of hydrogen ions. So that is what we are trying to counteract. So this compensation mechanism would result in an elevation of carbon dioxide. So she hasn't yet started with any sort of respiratory compensation because her carbon dioxide levels are still normal. 19. Describe some other causes of the same type of acid-base disturbance. So anything that would result in an increase in bicarbonate ion production or retention, or a loss in hydrogen ions, would result in metabolic alkalosis. And again, here's a picture, and take home here is that with metabolic alkalosis, pH and bicarbonate levels move in the same direction. So pH would be high, bicarbonate levels would be high. So other causes other than excessive vomiting, which we covered in this case study, would be an overdose of antacids. So antacids, you're essentially taking bicarbonate ions to counteract your stomach acid. It can also occur with the imbalance of other electrolytes like potassium and chloride, because as these electrolytes are regulated in the kidneys, that can cause your kidneys to end up secreting too much hydrogen ions in trying to hang on to these other electrolytes, and that can also indirectly cause metabolic alkalosis. And so now we'll wrap up part 1 with a conclusion and a summary. And this little Colosseum picture is to help you remember the mnemonic Rome. So when you have a respiratory condition, the pH and carbon dioxides will be opposite. So pH would be high and CO2 would be low with alkalosis. pH would be low and CO2 would be high with acidosis. So that's the respiratory alkalosis and respiratory acidosis. And then with the metabolic conditions, your pH and bicarbonate levels will be equal in terms of their direction of change. So pH is high, bicarbonate is high, that would be alkalosis. pH is low, bicarbonate is low, that would be acidosis. So this would be metabolic alkalosis, metabolic acidosis. So they use this little trick to remember, Rome, R-O-M-E. So we're going to fill in this chart with the information that we have learned through these cases. So we're going to look at the 4 different disorders, what they do to the pH, the carbon dioxide, the bicarbonate, and then the possible causes of each type. So respiratory acidosis. So it's acidosis, so we'll have a low pH, less than 7.35. Carbon dioxide, in respiratory conditions, the carbon dioxide should always be in the opposite direction as pH. So the carbon dioxide levels will be high, greater than 45 millimeters mercury. The bicarbonate levels in respiratory acidosis could be normal, between 21 and 28 milliequivalents per liter, but you may also see them be high with compensation. So once renal compensation kicks in, you could have higher than normal bicarbonate levels. The possible causes for respiratory acidosis is anything that can cause hypoventilation, which is a reduced breathing ability. So respiratory alkalosis. So it's alkalosis, so the pH will be high, greater than 7.45. Again, if it's a respiratory problem, pH and carbon dioxide will be opposites. So if pH is high, carbon dioxide levels will be low, so less than 35 millimeters mercury. Again, if it is a respiratory problem, then the bicarbonate levels will be normal in the acute phase. And then once compensation has kicked in, the bicarbonate levels could become low. Causes of respiratory alkalosis are anything that causes hyperventilation, which is an increased breathing rate. So now let's look at the metabolic conditions. So metabolic acidosis, so acidosis means lower than normal pH, so my pH would be low. Now my carbon dioxide can either be normal, between 35 and 45 millimeters mercury, or it could be low if compensation has kicked in. And then the bicarbonate levels will also be low. So bicarbonate levels will be less than 21 milliequivalents per liter. So this is what I was telling you earlier, that in the metabolic conditions, you have an equal move in the same direction. So pH is low, bicarbonate would be low. Possible causes of metabolic acidosis is anything that causes excessive hydrogen ion production, like lactic acidosis, ketoacidosis, etc., or anything that would cause bicarbonate loss, like diarrhea. And then with metabolic alkalosis, it's alkalosis, so our pH is high. Again, our carbon dioxide could be normal in an acute phase, but if compensation kicks in and you have a decreased breathing rate, that could cause the CO2 levels to become high. So again, if you have a high pH and it's a metabolic condition, you should have high bicarbonate levels. So bicarbonate levels should be greater than 28 milliequivalents per liter. And metabolic alkalosis is caused by anything that causes a loss of hydrogen ions, like vomiting, or an excessive gain of bicarbonate ions, like an antacid overdose. So that is another way to study these different conditions. This was also the flow chart that was given to you in your textbook, where again we go through the steps of checking pH first, then checking carbon dioxide levels, and then checking bicarbonate levels. And then, as mentioned in the lecture, if you want to differentiate between whether your metabolic acidosis was caused by a loss of bicarbonate or if it was caused by a gain of hydrogen ions, you can also use the anion gap. So number 21, differentiate between fixed acids, metabolic acids, and volatile acids. So fixed acids are acids that remain dissolved in the body's fluids and so can only be removed by the kidneys. So they're fixed in the fluids until the kidneys can get rid of them. These acids are generated during the breakdown of amino acids, and this is how we get sulfuric acid, and the breakdown of compounds containing phosphate groups, and this is how we get phosphoric acid. Metabolic acids are acids that participate in or are byproducts of cellular metabolism. So for example, pyruvate, which is pyruvic acid, is produced during glycolysis and used by the mitochondria during aerobic respiration. Lactic acid and ketone bodies can also be produced during these processes under certain conditions. Like we talked earlier about how if you have a condition of hypoxia, you can start producing extra lactic acid. And then volatile acids are acids that are able to leave the body's fluids by becoming a gas and being exhaled by the lungs. And so, for example, as we saw previously, carbonic acid can be converted to carbon dioxide, which can be exhaled through the lungs. Number 22, what is the most common acid-base disorder? So remember, almost every cell in the body contains mitochondria. Mitochondria perform cellular respiration to make ATP, which is the cell's main energy molecule. Carbon dioxide is formed as a byproduct of these mitochondrial reactions. So your mitochondria are your cell's energy factories. They are taking in glucose and oxygen and using them to make ATP, and as a side effect, they are producing carbon dioxide and water. So the body is constantly producing carbon dioxide, which can be converted to carbonic acid and then to hydrogen ions, as we saw earlier. In addition, you also have fixed acids and metabolic acids being made, so the body is always fighting against acidosis. Therefore, acidosis is always going to be more common and more likely than alkalosis. And since it only requires a short period of no breathing or slower than normal breathing for carbon dioxide levels to build up, respiratory acidosis is the most common acid-base disorder, followed closely by metabolic acidosis, which would be the second most common acid-base disorder, because for the reasons just explained, we are always fighting against acidosis. So part 2, fluid and electrolyte balance. A 68-year-old man with chronic renal failure was in the hospital in serious condition resulting from a heart attack. He had just undergone balloon angioplasty to redilate his left coronary artery and was thus on an NPO diet. This means he was not allowed to have food or drink by mouth. He received fluid through an intravenous or IV line. Late one night, a weary nurse who was on the 11th hour of a 12-hour shift came into the patient's room to replace the man's empty IV bag with a new one. Misreading the physician's orders, he hooked up a fresh bag of IV fluid that was twice normal saline rather than half normal saline. In other words, the patient started receiving a fluid that was 4 times saltier than it should have been. This mistake was not noticed until the following morning. At that time, the man had marked pitting edema and had inspiratory rales, which are wet-sounding crackles at the bases of the lungs on each side. He complained that it was difficult to breathe as well. Blood was drawn, revealing the following. Sodium level was high, so it was 157 milliequivalents per liter. It should have been between 136 and 145. His potassium level was normal at 4.7 milliequivalents per liter. A chest x-ray revealed interstitial edema in the lungs. Number 1. Was the saline added to the ECF or ICF? What two components make up the ECF, and can both water and dissolved ions move between these two components? So the saline was given to the patient intravenously, meaning that it was injected into a vein. So since the saline was being added to the blood plasma, it was added to the extracellular fluid, or ECF. The two major components of the ECF are the blood plasma and the interstitial fluid in the tissues. And then remember, our other water compartment is the intracellular fluid, or ICF, which is the fluid inside of the cells. Yes, both water and dissolved ions can move between the plasma and the interstitial fluid at the capillaries. So at a capillary, you can have water and solutes cross over from between the plasma and the interstitial fluid. And then just as a note to remind you, water and solutes can also move between the ICF and the ECF through channels and transport proteins in the cell membrane. Number 2, would the nurse's mistake increase or decrease the saltiness or solute concentration of the interstitial fluid? So since the fluid that was given to the patient was twice normal saline and the doctor had ordered half normal saline, the solution given was actually 4 times saltier than it should have been. So since water and electrolytes can easily move between the plasma and the interstitial fluid at capillaries, the administration of this fluid would increase the solute concentration of the entire ECF, which means both the plasma and the interstitial fluid. So yes, it would increase the saltiness of the interstitial fluid. So now the ECF is more hypertonic than it should be, meaning it has a higher concentration of solute. So if you look at the different types of fluids that can be administered in a hospital, what we call normal saline is isotonic to the ECF. What the doctor had ordered for this patient was a hypotonic fluid, which would have been half normal saline. And what the patient ended up getting was a hypertonic saline, so a hypertonic solution. So this is actually a pretty dangerous condition because it's opposite of the tonicity that he should have gotten. Number 3, given your knowledge of osmosis, will this cause the cells in the body to increase or decrease in size? Explain your answer. So again, this mistake caused the ECF, or the extracellular fluid, to become hypertonic compared to the ICF, which is the intracellular fluid. So it would be hypotonic by comparison. Water always moves by osmosis towards the area of higher solute concentration, so water moves towards a hypertonic solution. Thus, water would move out of the ICF and into the ECF to correct this balance. So we would have movement out of the cells and into the ECF. This will cause the cells to shrink slightly, but probably even more important, it would also cause an increase in blood volume, which would cause an increase in blood pressure. Number 4, why does this patient have edema and inspiratory rales? So the increase in water coming into the ECF will raise blood volume and blood pressure. It will also increase the amount of fluid in the interstitial tissues because remember the ECF is both blood plasma and interstitial fluid. So the increase in blood pressure will raise the hydrostatic pressure on the arterial side of capillaries, meaning that more fluid and solutes are going to be forced out of the blood plasma and into the interstitial fluid. So the increase in capillary filtration in the capillaries, along with the increased fluid moving into the interstitial tissues from the ICF, will cause edema. And so they actually mentioned in the case study that it was pitting edema. So when you see pitting edema, that is edema where you can like press your finger up against the patient and that divot that you make will stay there for a while. And the inspiratory rales is as a result of the edema in the lungs, which is called pulmonary edema. This man's problem is further exacerbated by his renal failure. So that was what he was in the hospital for, or he has chronic renal failure. He was in the hospital for a heart attack. And so with the renal failure, this is going to prevent his body from excreting the excess sodium and fluid. His heart attack could have also damaged the left side of his heart. This could result in decreased blood being pumped out to the systemic circuit, which could cause a backup of blood in the pulmonary circuit. This could further increase the hydrostatic pressure in the pulmonary capillaries, and this would further aggravate the pulmonary edema. Number 5, how would this increase in salt affect the patient's blood aldosterone level? In your answer, explain the source and function of the hormone aldosterone. So aldosterone is secreted by the adrenal cortex, and more specifically the zona glomeralis of the cortex, and it functions to increase sodium reabsorption in the kidneys, which can also cause the secretion of potassium into the urine. So aldosterone also indirectly helps to increase blood volume because by allowing the body to retain more sodium ions, the body can also retain more water. So remember the little phrase, water follows salt. Thus, aldosterone will help to correct hyponatremia and hyperkalemia. So it would help to reverse the conditions of having too little salt in the body or having too much potassium in the body. So aldosterone, when you have higher levels of aldosterone, you're going to reabsorb sodium and excrete or secrete potassium. And when you have lower levels of aldosterone, you're going to increase the excretion or secretion of sodium, and you're going to have more reabsorption of potassium. So since this patient has too much sodium in his body from the twice normal saline, we would expect to see lower than normal levels of aldosterone in this patient. So this patient is actually suffering from hypernatremia too much salt in his body, so his aldosterone release would be inhibited. Number 6, can you think of any other normal mechanisms that the body has to control salt and water balance? How might they react in this situation? So the increased blood volume and blood pressure could cause stretching of the heart muscle and the release of the natriuretic peptides, so the release of ANP and BNP. The natriuretic peptides would reduce his thirst and block the release of ADH and aldosterone. Yet another reason why we would expect to see lower than normal levels of aldosterone in this patient. However, there is also a unique circumstance in this patient. ADH is secreted based on input from osmoreceptors in the hypothalamus. So normally, when you have a high salt concentration in the body called hypernatremia, it is accompanied by a decrease in fluid, like dehydration. So we talked about in the lecture how dehydration is linked to hypernatremia. So in this case, however, the patient was given both fluids and extra salt, so he's got an excess of both, and this is not something that typically happens in nature. So the osmoreceptors will only sense the increase in salt concentration, and they will actually signal for ADH to be released, because again, normally when you have an increase in salt concentration, it is because you are dehydrated. So ADH would increase this man's thirst and cause his kidney to retain more water, which is actually going to be counterproductive in this case, since this man needs to lose excess fluid as well as excess salt. He also has competing signals. He's got one signal from the osmoreceptor saying, yes, I need ADH, but he's also got signals from the natriuretic peptides saying, no, I don't need ADH. So he also has conflicting signals going on as to whether or not ADH should be released. And yes, there have been accidental deaths due to mistakes and people getting hypertonic solutions when they shouldn't. So it is very important, if you do work in the medical field, to make sure that you are putting the correct type of solution that was ordered into a patient's IV. And that is the end of the Chapter 27 activity.